Welcome to the Academy of General Dentistry podcast series featuring Dr. George Schmidt. Each episode features experts in the field of dentistry who share insights and inspiration to help you succeed. Let's get started.
Welcome back, everyone. We have another great show for you today as we welcome Dr. Dale Miles to the program to talk about CBCT imaging and diabetes. But before we introduce our guest, make sure you subscribe to our channel, hit the like button, and ring that bell. That way, you'll be among the first to be notified of all things AGD. Hey, Dr. Miles, how are you?
I'm doing great. Thank you, George. Thanks for the opportunity to podcast with you.
Yeah, we're really looking forward to some great informative conversation. So let me just give you the audience a little bit of background on you. So Dr. Miles was chair of the Department of Oral Health Sciences at the University of Kentucky, the graduate program director of diagnostic sciences at Indiana University, and has held many positions at the University of Connecticut and Dalhousie University and the Arizona School of Dentistry and Oral Health, where he was the first associate dean of clinical affairs. A diplomate of the American Board of Oral and Maxillofacial Radiology and the American Board of Oral Medicine, Dr. Miles has been selected as one of the top clinicians in CE for the past 17 years by Dentistry Today. He has authored over 140 scientific articles, 6 radiology textbooks, and the best-selling atlas on cone beam imaging, Atlas of Cone Beam Imaging for Dental Applications. Dr. Miles currently has a full-time practice in Fountain Hills, Arizona, and an adjunct professorship at the Woody L. Hunt School of Dentistry Medicine in El Paso, Texas. To this date, he has read close to 40,000 cone beam scans. And Doc, that's a lot of voxels to look through.
Good point, George.
Yeah, that's a lot of stuff. So one of the things I want to talk to you about today, or what we'll talk about, is medial arterial calcification. And that's a diagnostic marker for type 2 diabetes, and that can be seen on CBCT images. And we want to talk about that and have you help us learn a little bit more about that. But before we do that, I want to talk a little, take a step back and talk a little bit about CBCT in general and some of the more basic things that some of our listeners may encounter. And let me just start out with this. My training has always been, or I was taught, when I had first gotten into this, that, whenever you're set out to do some type of procedure, to take the minimal field of exposure necessary to do what you need to do. So am I going down the right road with that? What's your feelings about that? Is that the right thing? Is that the wrong thing? Should we focus minimally or expand that greatly?
Well, that's a great question, George, and it doesn't have an easy answer. You have to establish an office protocol, and the office protocols depend on what your tasks are, what your diagnostic tasks are. So you're kind of going down that road that if I'm doing a single implant, maybe I need a smaller field of view. However, it's operatively driven, restoratively driven, so you obviously need the occlusion. If an implant is placed and it's high and the patient becomes symptomatic because the temporomandibular joint region gets involved or the muscles, you possibly should have the temporomandibular joint in your implant case. So if you're just doing plain old, dental caries and periodontal, zoom whitening or whatever, yeah, you can get by with a smaller field of view. I would say minimum 8x8. I would also say that you really do need a multifunctional machine. You don't want to give up the panoramic. It's just too good an image. And we understand that one. We're only just getting to understanding CBCT. So if that's your approach, minimal volume for the diagnostic task, I think that's a reasonable approach. But as you know, one of the big areas besides implant is obstructive sleep apnea, or sleep disordered breathing. And that requires, at least, 10 by 14, 50, whatever. So the structures that are in there are not quite as understandable to most dentists. They're getting better at reteaching anatomy and looking at larger fields of view. So, it's a curveball question for me because I think, given that there's a patient on the end of the tooth, that we should actually take probably a good size volume on every patient because there's things in there that we can catch that affect the patient's whole health.
Absolutely. So one of the reasons I ask that is I think a lot of people don't realize, and I want you to speak to this because I know you do some expert witness testimony and things like that, that whatever you image, you're responsible for diagnosing everything in that picture, correct?
Absolutely. You can't abrogate the diagnostic responsibility. If you want, you can send them off to people like me or my colleagues that are oral maxillofacial radiologists and have a formal read. Um, However, there are lots of dentists that don't take that many volumes that want to look at their volume themselves and basically pick out the pathology and use it to do their tasks. So, it's an interesting sort of approach. I think dentistry is becoming more holistic in terms of treating the whole patient, and we're finding out that there's some correlation between the inflammatory things that we see in the periodontium and cardiovascular disease, as well as diabetes. There's a lot of people out there that have malocclusion problems and other problems because of obstructive sleep apnea, and I think dentistry is moving towards more medical approach to the patient.
Yeah. So do you recommend, so for the folks out there that are using CBC technology and they are, scanning and things like that, do you recommend sort of looking at the scan first and taking a look at it? And if in your opinion, there's no issues, it's okay? Or do you recommend you think we should send every scan that we take out to radiologist for a report, a written report, and then have that, back for the patient for documentation and things like that? What do you feel about that?
Another great question. I think I didn't supply these to you, did I?
Mhm.
I get that question just about every time I lecture. I don't feel that, every scan needs to be read by an oral maxillofacial radiologist. We couldn't keep up. Trust me, the number of scans sent for a formal read in the US at this point in time is around 10 to 14%. So a lot of people aren't sending them. But like you identified at the beginning, you're responsible. You should look at it first. In fact, one of the problems that I see is that the manufacturers that sell you a machine have a standard way of displaying that information for you. You get 3 planes of section and some stylized image, like 3D surface rendering, or I call them holograms, sometimes a grayscale image. But when they do that, they pick out the midline section of each slice, the midline of each anatomic plane, and they give you axial, sagittal, coronal. So what do you do as a dentist? Well, we're task oriented. So what we do is we drag our little lines to the implant site or the apex of a tooth, and we start to look at that. Well, what did you just do? You missed looking at the rest of the volume. So your question is very appropriate, because I think, and I teach dentists in the courses that I give, they need to look and evaluate the entire volume first and start with a plane of section that they're comfortable with. I always suggest coronal, because it's like looking at a big panoramic if you've got a larger field of view. And we understand looking at the patient from sitting in the chair because of the way we approach panoramic. So yes, every scan should be looked at in its entirety. If you don't see something, I call them an I don't knowma, okay? Then all you have to do is send that one in. So dentists don't need to send every one of them, but if you're doing 10 cases a week, like in some of these high-end implant pros practices, yeah, you should probably send them out, because you just don't have the time. You don't make your money looking at a scan. You make your money doing the restorative and operative dentistry in your practice.
Yeah, I think the bottom line here is just like anything else. You've got to get the proper training, and I know you have some really great courses, and we'll ask you how we can find out a little bit more about that later. But you really got to get the training, so you know the normal, and you know what's not normal. When you see something that's not normal, that's absolutely got to go out of there. Has to go out. Um,
Correct.
do you think? And I was going to ask you this too, but you kind of alluded to it. So every time you're looking at a scan, do you have sort of your step-by-step way that you look at it? You look at the macro, and you kind of alluded to it before. Look at the big picture, and then you kind of boil down to what you originally intended to take the scan for in every case.
Yes, and when I take that approach when I lecture, and what we probably will put it in a some type of article either on my website, or we might publish it. Um, I take one plane of section, I scroll through the slices, and if I see something, I take a screenshot. Very easy to do in all the softwares. If I see something that looks unusual in a plane of section, I'll go to another plane and verify that, oh yeah, that's the same thing I'm looking at. I rarely look at all three planes at once on the screen. When I'm finished, I have a set of images that I can actually, as a radiologist, put on my headset, dictate my report very efficiently and not miss anything. So dentists need to do that too. And if in that set of screenshots, there's something that you go, oh my God, what is that? Then send that case out, to a radiologist for, a formal report.
Yeah. So for some of the procedures that we do, implants, for instance, are we heading towards CBC technology as standard of care?
I think so. I wrote an article, which will send the folks that watch this, this podcast to my website, drcomby.com. I have about 30 articles on that site. And basically, one of the questions that I kept getting early on in CBCT was, is it going to be the standard of care? And I think for certain tasks, it is. And it's an argument that goes up and down. But in the litigation cases I've been involved in, even third molar extraction, mandibular third molar extraction, if you don't do CBCT, most lawyers will convince a jury or a judge that you should have. Okay, so it is being adopted as a standard of care for many tasks. And I think implants, sleep apnea, and third molar and or other impacted tooth scenarios really require CBCT. It just makes your whole life easier.
Yeah, I don't see why, I don't see why we wouldn't be doing that for sure. I mean, I wholeheartedly believe in that. That's for sure.
Yeah.
So you mentioned a couple of things, you mentioned a few times you wrote some great articles, and I know you got a lot of stuff out there, and you're going to tell us how we can look at that. But one of the articles that you wrote, maybe a couple years back now, is detection of medial arterial calcification on CBCT images of a patient with undiagnosed type 2 diabetes mellitus, a case report. So let's talk a little bit about that, and let's talk about the article first and what we should be looking for and how this is beneficial.
Yeah, I've got about a 3-hour talk on that, but
yeah, we'll boil it down.
we'll give you the Cliff Notes version.
Give us the ChatGPT note. Yeah.
All right, and I'm glad we're doing video because I can use my hands, to explain. I'm going to take you back to your histology of an artery. Okay, the intimal layer, the inside layers, the tunica intima. It has an endothelial lining. This is where the schmutz comes from perio and all the inflammatory products, and it's permeable. It allows things to go through into the next layer. Well, there's inorganic phosphate there. There's lots of inflammatory mediators. When they get to the next layer, which is called the tunica media, or the medial arterial layer, they stimulate vascular smooth muscle cells in that layer to lay down bone. We get bone in the artery. Okay, that is the true hardening of the arteries. But the unique thing about it is that, think about the medial layer as that muscular layer. It's expanding and contracting based on vascular demand. When it's calcifying around the arterial wall, the medial wall, not the intimal wall, that's just blockages. Okay, and you can go a lot before that's calcified. If you have a fibrous plaque there with some schmutz in it and it throws a piece, it can go to your heart, your lung, your brain. You have a stroke, heart attack, or a pulmonary embolism. So what happens is, in a more slowly progressive process, the medial layer gets calcified and there are patterns. I see them all the time. I've got over 700 cases now. And I've got more probably because when I've gone back to look at my arteriosclerotic cases, I go, oh my God, here are the patterns. I got to shift that over into the medial arterial calcification. When I've sent my client the recommendation at the report, patient needs to be seen for undiagnosed or uncontrolled type 2 diabetes. Hemoglobin A1C is, required. When they come back, the dentist will phone me up and say, my patient did have the high diabetes. How did you know? And I go, I saw it in the arterial wall. So I've been doing this. I could give you a list of articles of medial arterial calcification that I've produced, but it's coming out also in the cardiovascular literature, the nephrology literature, people that look at just arteriosclerosis in some of those journals. They're going, it's time to revisit MAC because it isn't just something that we shouldn't be worried about. And we focus so much on intimal plaques and blockages and putting in stents that we've missed this other more diabolic, slowly progressing problem that the diabetics have. And the sooner you get a diabetic into treatment, the better off they're going to be. Quality of life. They don't end up with a below the knee amputation. They don't end up in renal dialysis because of kidney failure. At least they don't right away. They can be treated.
Yeah, and so many of our patients have this. I mean, I'm looking at some of the statistics related to the article that you have out there. And as we all know, it's so prevalent. Something 100 million adults have diabetes, another 88 million are pre-diabetic. So almost 200 million Americans that are afflicted by this condition or will be afflicted by this condition. So it's critically important. So when you take your scan, you look, of course, this is in the macro, the macro phase of when you're looking at everything there. Where are we looking for this? I mean, where are we going to see this? On what scan am I going to see this?
Okay.
What segment?
Well, we got it. Sorry, I didn't mean to interrupt.
Yeah.
We got excited because we saw them in the cervical component of the internal carotid artery, okay? And that became quite apparent. But you know what? A lot of those cases weren't just arteriosclerosis. When I tip them into a different plane of section, when I do a 3D image and rotate it, it's wrapping around the arterial wall. So I see circular calcifications. I see parts of circle, which we call curvilinear calcification. And this is all validated in the literature, and even by ChatGPT, by the way, because I use that quite a bit, and also linear parallel calcifications. Think about the carotid as it goes from the neck up. If you have calcification on both walls, you'll see linear calcifications that parallel. Now, the carotid artery doesn't stop in the neck. Dentists stop in the neck, okay, on their panoramics and whatever. It goes up. It goes just about, are you ready for this? A centimeter medial to the condylar head, okay? Then it goes up through the foramen lacerium and up past the sella turcica above the sphenoid sinus. Well, when it makes a big loop up in that area, I see these circular calcifications in the clinoid segment, the ophthalmic segment, and they're so apparent, even at thin slice. What I suggest people do, and they can do it in softwares that they have with their machines, some of them, and I don't want to lay them out there, but I use a third-party software that I can do it all the time. I change the thickness to 5 or 10 millimeters, and then I apply a filter. And everyone's got this filter. It's called an MIP filter. Mm-hmm. Hardly anybody uses it, okay? But when you thicken it and apply the filter, the calcifications go pop, and you're able to see them. So it's amazing. Once people see them, I have them call me back and they'll say, yeah, now I know what you were talking about. I see what you were saying. So I'm kind of on a mission to get this information out there. And this is a great first start. And I really appreciate the opportunity to join.
Yeah, it's so important. I mean, it's so important. So would this be something that obviously we should all be looking for this, but if we think we see something like this, is this something that we should refer to the radiologist for clarification prior to making a referral, or how should that process work? Walk us through that, and who should we refer to and things of that nature?
Well, first of all, if they're a known diabetic, you'll see them, okay, most likely. If they're pre-diabetic or undiagnosed or even uncontrolled, and you think you see some of these calcifications, they're at high risk for hypertension and stroke anyway. Well, take your blood pressure again in the office, okay, maybe confirm that. Beginning and end of appointment. Then yes, if you start sending some of these out, you may get some pushback from the primary care provider. Oh yeah, we did ultrasound in the neck, but we didn't. They're looking for blockages. They're not looking for these patterns. So the hemoglobin A1C is got to be a recommendation, and it can come from the dentist. I mean, we do have a CDT code for testing in the office for that, and this is why I think that down the road, we're going to be doing hemoglobin A1C quite frequently in the dental office. You mentioned my appointment as an adjunct professor at Woody L. Hunt, the new school in El Paso, Texas. Mm-hmm. The adjunct, I don't go there. I stay here, but I go there and visit periodically. it's to do research there. They have high population of Indian, Hispanic, okay, and Black, which are higher populations for diabetic risk. And guess what? Their protocol, when they have a new patient come into school, they do a hemoglobin A1C right off the bat. If they're scanned, then they look for the calcifications. So this is going to be a routine thing, in my opinion, probably long after I'm gone. But I think it's going to be a routine thing that we do in dental offices and certainly in most dental schools, probably in 5 to 10 years.
Yeah, such a great service to our patient pool. I know you practice a little bit too. So let me ask you this. Are you scanning every patient that comes in, or are you only scanning for specific procedures?
Well, I'm looking at every patient that I get because, George, I don't scan. I'm in my office in my study in Fountain Hills, Arizona, and I have a server that my clients upload the cases to. I download, I put them in the software, I make the images, I do the report. So no, but I have, as you saw, an inordinate number of cases that I've looked at since 2005, and I'm educating myself constantly as I look at these cases. So I need to bring this information, to the dentist. Now, should you scan every patient? Because that was basically your bottom line question.
Yeah.
I don't think so. I think now this is where I think, you have to look at your tasks. You have to, this is how I tell dentists to justify the purchase of their CBCT if they're on the fence about buying one. How many of these cases do you do? How many of these cases do you do? How many of these cases do you do? And if they total it up and they say, okay, I'm going to do 4 to 5 scans a week over a 200-day working year, all of a sudden they go, oh my God, I can really easily afford this machine, at $299 a scan or whatever. And they're doing the easy part. They're just taking the image. I'm doing the hard part along with my radiology colleagues because it takes a while to go. It takes anywhere from, I would say, 15 minutes to probably 25 minutes to get the data, put it in a report, bundle it all up, download it from the server, upload it to the server. So, and I only get my fee for that. So.
Yeah, that's for sure. So I know you said you were doing some research at your position, your adjunct position there. So is this MAC, the medial arterial calcification, something you're doing more research on actively right now?
Yeah, we're doing it constantly. I have a good friend down there, Dr. Robert Danforth, who's actually full-time radiology in the school. So he and I are kind of working together. We also have the medical radiology group involved. I went down to speak to their neuroradiology people, and at the end they said, yeah, you're right. We don't have time to separate MAC from arteriosclerotic plaque. We just say arteriosclerotic plaque because they dictate a case in under a minute. Okay. And they were saying, yeah, we get it. We should be separating these. So we've actually incorporated them, and they have a huge diabetes research group down there. So I'm not on site, but I'm in a good environment to really push this information forward because it's going to change the paradigm significantly, and dentists can be a part of it once they are taught how to recognize the patterns.
I don't think there's any question about that. And you're a really busy guy because I know you got a lot of other things going on. And one of those, you've got an app out there called Scanatomy. So tell me a little bit about that because I know a little bit about it and it looks really fantastic. So talk to us about that.
Yeah, it's just a little app that we had that we put in most of the normal anatomy that you'll see in the 3 planes of section. We put it in a quiz format. So if you bring up a plane of section, it'll say the structure marked, and then it's A, B, C, D. Okay, you find it, you look at it. Is which of the following, and then you click on your answer. If it's right, you get a green box. If it's wrong, you get a red box, and you go on to the next one. Once you've gone through the 3 planes of section, the slice data that we have in there. First time I have people go through like, oh my God, I only got 40% questions right. By the 3rd or 4th time they do it because we scramble the answers, okay? They go, this is great. I love it. When's version 2.0 coming out? And I go, there's only so much anatomy. But it's an app that's right on, Apple's App Store. I do not have it for the Droid. So if anybody out there is a dentist, a young dental student that knows how to program on for Droid, contact me. Okay.
There you go. There you go. Who needs Indeed when we have Dr. Miles here on the podcast? Also, I know Dr. Conebeam, that's your main site there. We've got a lot of great information. I was looking at that earlier today, and you've got some wonderful information on there. Tell me a little bit about that home site where we can get all this good stuff.
Yeah, that site's been up since probably 2005 or six when I left academia and went into full-time practice. And basically, you can't purchase anything there. There are links to things like Scanatomy and the Conebeam Atlas, but it's really informational. I have it broken down into principles, applications, risk and liability. There's probably at least 30 articles in there. There's some video. They're mostly short segment videos. There's nothing long and instructional, but I've been working on slowly putting up maybe 40-minute webinars that I might monetize it at this point, because I get a lot of traffic and people want that kind of instruction. So eventually I might do that as well, but mostly it's informational for the dentist to understand CBCT.
Absolutely. And if we wanted to find out where we could find where you're speaking and things like that, that's all listed on there too, I think, right?
Yeah, I haven't updated it for a while. My webmaster's getting after me to say, don't you have some meetings this year? And we'll be posting those in a little
There you
bit.
go. All right. So we're going to task you with that so we can get that. So I would be remiss if we didn't talk a little bit about AI when we're on here. And so I've got to ask you AI and its impact it has on oral and maxillofacial radiology. And what do you think the future, holds with that? I mean, it's such a huge subject. There's so many companies out there. I don't want to mention any names that are sort of on the cutting edge of this, and they have, various things that they're developing. Where are we going with all this?
Yeah, AI is just the tip of the iceberg. After AI becomes machine learning and then neural networks, I mean, there's a whole gamut of things that eventually lead to some machine-driven diagnostic tool. I don't think we can get around it. It really is just a diagnostic helper. It's not going to replace the dentist and or the radiologist anytime soon because unfortunately, fortunately for us, the best computer is right here. We can factor in things that AI can't. AI is looking for things like patterns, okay? It can correlate certain things, but it can't come up with the final diagnosis necessarily. Every AI manufacturer of diagnostic dental AI ilk, they basically have a disclaimer that says, we're going to show you this. We're going to point to the things that, have been found in the scan or the 2D, 3D images. And then it's up to you to make the final decision. And that's good because it doesn't have the patient. It doesn't know the history, the family. There's a lot of things that factor into AI that go on in the human brain and not just, on an image on a screen. But it's here to stay. And that's only the tip of the iceberg. AI has been around forever. I mean, the cutest example I can give you is a friend of mine got an Alexa, okay, which uses AI. He said he's showing off, turn on the music, turn on the lights, do whatever. I said, can I ask the Alexa a question? And it'll show you at least some programmers have humor. I said, Alexa, do you have a boyfriend? And it came back, I'm kind of attached to the wall right now. So
Yeah,
AI is written by humans. The coding is by humans.
Yeah,
they have to have the data, and the AI programs are only as good as the data going into it. So
yeah.
we'll be around for a while as dentists and as radiologists.
Okay, I'm going to hold you to that. It's comforting to know that we're not going to be obsolete anytime soon.
Nope.
So that's really good stuff. Hey, listen, so a lot of great information here. If folks had more questions, if they wanted to book you to speak, if they have, how can we contact you?
Yeah, I'm a simple guy. My email address is miles.dale@gmail.com. There's also, you can get to me through the Dr. Conebeam website. And I've just launched an AI report software of my own, a new version called EasyWriter.ai. and there's a link in there. In fact, we just put it up, and I have a few questions already from people that went looking at it just the last day or two. So I'm easy to get to. miles.dale@gmail.com.
Outstanding. Thanks so much for coming on the program. Great conversation.
Thank you for the great questions, George.
Yes, absolutely. And we'd also like to thank our producer, Kristen Gover. If you like what you heard, please like and subscribe to our channel. You can always find us on Spotify, the AGD app, SoundCloud, Apple Podcasts, and YouTube under @General Dentistry. If you have any questions, concerns, comments, or suggestions, contact us at news@agd.org. Thanks again, and we'll see you next time.